So welcome everybody. Thank you for taking the time out of your morning, your evening, your afternoon, wherever you may be calling in from today to join us for our webinar. This is the second in our mental health series. So I hope you've had the opportunity to review our on-demand recording of the first one, if you have not already. Before we go ahead and get started, I just want to do a little housekeeping and let everybody know that we will be accepting Q&A at the end of our webinar today. At any point in time, if you have a question that you want to ask and you maybe don't want to forget that question, feel free to use the chat feature, the Q&A feature in your Zoom panel. But just know that we're not ignoring you. We will get to that towards the end of the session today. Now I'd like to take a moment to introduce our wonderful presenter, Whitney. Whitney Fear is an enrolled member of the Oglala Lakota tribe. She was born and raised on the Pine Ridge Reservation, where her family has a small cattle operation. After finishing high school in 2005, Whitney moved to the Fargo-Moorhead community, where she discovered a drive to pursue nursing as a career. She worked in emergency medicine, mental health, and community health. While working in homeless health services at Family Health Care, Whitney made the decision to pursue advancement in her nursing education to expand the services that she could offer to her patients. Whitney completed her Master's of Science in Nursing in August of 2019 and is an ANCC board-certified psychiatric mental health nurse practitioner. She is awaiting certification. I believe this actually I might have an older version, because I believe you just received these credentials, and I will let you correct me on that, for the perinatal mental health after receiving completing the necessary requirements. Whitney is currently working at the Family Health Care in Fargo, North Carolina. And my screen just got wonky on me. So I'm going to go ahead and turn this over to Whitney. She can certainly correct my mistake there, for cultivating emotional wellness in rural communities.
Okay, well, thank you. That was actually my mistake to not get you an update.
I just talked to you about it.
I passed the certification exam when I hadn't yet. It's embarrassing to backtrack if you don't pass. So I'm going to get the slideshow pulled up here. Okay. All right. So thank you for the introduction. I wanted to include some contact information in case participants had questions after the presentation today, and also to take an opportunity to briefly explain my connection to rural healthcare. I grew up in a very rural area. Actually, I drove like 40 plus miles to school every day when I was in high school. I went to grade school in a 2-room country schoolhouse. Both sides of my dad's family are cattle ranchers. There are not many people living a rural lifestyle these days, and there's something very special about that for those people who continue those traditions. My grandmother's side of the family has had cattle operations for 6 generations, and my grandfather's side of the family has been ranching for 5 generations. My great-grandfather, Charles Livermont, who's pictured there all the way on the right, was one of the most respected cattlemen of his time.
Whitney, I don't mean to interrupt you. Your screen share is, I don't see it. So so I just want to ask if anyone that's watching can see the screen share, can you please drop me a note in the chat? I want to make sure it's not just on my end.
Let me, you know what? I don't think that I got it clicked all the way. So that was my mistake. Now it should be going, right?
Yes, now I have you perfectly. Thanks.
Sorry.
Yeah.
Okay, so this is the slide I was on. Okay, my great grandfather, Charles Livermont, used to actually ride the train with his cattle to sail from the old family place all the way to Omaha, Nebraska, which would have been like a 12 to 14 hour train ride roughly. In that picture on the right, that's the day he would have went to sail with his cattle. Unfortunately, our family has experienced issues of scarce mental health services in a rural area firsthand. Two of my grandmother's brothers died from alcoholism at a very early age, and my uncle, my dad's brother, died from suicide at the age of 19. So, an introduction, despite rural communities experiencing mental health and substance use issues that raise comparable to their urban counterparts, there exists a lack of resources to match the needs of those communities. The National Rural Health Association has identified the following issues as contributing to the lack of comprehensive mental health services in rural areas: accessibility, availability, affordability, and acceptability. Residents of rural health areas are no strangers to the experience of having less or none at all of what is available in urban areas in general. The tenacity of these rural communities to do much with less may be one of their greatest strengths. And by identifying the needs of those rural communities and tapping into the resilience that already exists within those communities, healthcare and human service providers can begin to develop creative and effective solutions to serve those populations. Here's the objective. I'm going to give everybody just a moment to kind of review those. So, in rural communities, there are many layers to issues of accessing mental health services. There are fewer specialty providers in general, not just mental health specialists, endocrinology, neurology, other specialists. And patients may have to anticipate traveling long distances to see a specialty provider. Telehealth may not be an option either due to comfort level or access. In these areas, there may be issues with coordinating those services also, and individuals can feel overwhelmed by having to do that all themselves. Whereas if they were in an urban community, they might have a social worker, a community health worker to help them with coordinating those services. If someone requires a really specialized approach to mental health issues, such as advanced therapy techniques like EMDR, or for those on the webinar that might not know that acronym, that's eye movement desensitization reprocessing. It's an advanced trauma therapy technique. Or medical interventions for mental health issues, such as electroconvulsive therapy or transmagnetic stimulation, they may have to travel even farther to receive those services. So those are some things that people even in urban areas have to travel to receive sometimes. As previously mentioned, telehealth is not always the best option for many individuals living in rural areas. They may feel far less comfortable with using the technology than those living in urban areas. I know many people back home that have never had a smartphone, and I've heard a lot of people as like unbelievable, like how could somebody like not have a smartphone? They don't work very well down there for one. Cell phone service is not great. It's kind of just getting to be where like back home on my family's place, you only have to drive 2 miles to get a cell phone signal, where you used to have to drive like 20. So things have come along, but they're not all the way there. So and a lot of people don't have a computer in their home either. I know that's the same thing with a lot of rural communities in the Midwest and the United States. A lot of them don't have a computer. They don't really feel like they have a need for one. For one, a lot of farmers and ranchers, they do their books on paper still. They don't do them on computer. They never have. And they, if there's something to take away for like part of that tenacity and resilience is that people, farmers, ranchers, and agricultural people are very convicted. And if they weren't, they wouldn't be able to make their places work for generations and generations, because it takes a lot of grit to keep going when there's like hard markets and things like that. So there's a lot of what I'm saying is there are a lot of rural people who are very stubborn, and that if it works to do their books on paper, they're not going to get a computer. So they may not have the type of high-speed connection that's required either. I do see some patients over telehealth, and we have kind of a hard time sometimes because their internet connection, their internet speed is not high enough for telehealth. It's really in and out. There's a lot of like freezing up, and the audio sometimes is really weird too. Not unusual for me to tell people sometimes, like, I'm just gonna call you on the phone. Is that okay? I saw you for a minute. like visually, I'm just gonna call you on the phone though, because this is like, probably frustrating for you to not hear me most of the time. So, and prior to the pandemic, and this is probably gonna, I think, probably become a growing issue again in the United States in any way. But prior to the pandemic, and this is again probably going to grow again to be an issue again. There were not insurance companies that would pay for telehealth. They would say it was unnecessary, that people could drive, that they weren't going to receive as high quality health care as they might in person. So they would require people to go be seen in person. And another complication of that is probably going to get thrown in the mix here, at least in the United States, is that has been kind of weighed by the pandemic, is that if the DEA decides to re-implement the Ryan Haidt Act, that would require providers serving patients over telehealth that are prescribing them controlled substances. So that'd be a Schedule 2 or 3 drugs in the United States, to see their provider in person at least once a year. So that's something that kind of again creates that complication of trying to have to plan that. So another issue that providers probably do a lot of coming and going. There might be residents that they're okay with doing their residency in a rural area or living there for a few years, but they have spouses and they have kids, and maybe they decide this is not for them. And that can be really frustrating for individuals who have had a hard time preparing themselves to seek those services in the first place, and then to have that provider they come to trust kind of leave, and to have that inconsistency. Individuals who this site is going to be kind of really geared toward the agricultural kind of workers and whatnot. And that would include like migrant workers too in the United States. Individuals who work in agriculture may have a stark contrast between their gross and their net income. When one sells their crops or cattle, they can appear to have a very hefty income, but so much of that goes right back to the bank to pay off your operating loans that you took out earlier in the year to cover those operation and production costs. So for example, what I mean by that is, so say a farmer takes out a loan from the FSA or the USDA or a private bank for $300,000 in operating costs. That's a lot of money, right? But that's going to pay for their diesel for their tractors if they need new equipment. It's going to pay for the seed, the pesticide, herbicide, all of that. And let's say from that $300,000 investment, they sell their crops, they made $250,000. They don't get to keep $250,000. They get to give $250,000 back to the bank and keep $50,000. So what their actual income that year is $50,000. Let's say they have 6 kids and a wife. That's then for a family, looking at then a family of 8, for $50,000 is not a lot of money. But what it's going to look like on paper is that they made $250,000 for 8 people. So due to that contrast, they can be disqualified for a lot of public assistance because their income is too high. They do manage to find another thing of that too is that they'll count assets. So all those tractors, that land, all of that's considered an asset. So then those assets could be millions. But whenever you're up against, do I sell off my place to get Medicaid? The place has been in my family. Again, some of these people, I know people who have had places 4 or 5 generations longer than my family has. And looking at, do I give up this place my family has had for 10 generations, that we've worked so hard to hold on to through the Great Depression, through horrible crop markets and cattle markets, whatever, and to get Medicaid, or do we just figure out how to make it work? If they do manage to find insurance, they may have issues with high deductibles and co-pays. It's become in the United States very common after the Affordable Care Act. Insurance companies have said, well, we have a larger risk pool, so we need to make deductibles higher, co-pays higher. And again, those are issues that could be pretty dependent on your location. I'm sure that I know that there are countries that have a little bit better public options than America does, frankly. The cost of traveling to urban areas to receive healthcare services can be difficult to manage. Imagine if you had to travel a few hundred miles every other week for therapy. Um, that is not a drive that you can make without probably needing to pay for a place to stay either the night before or after your appointment. Some procedures, medical procedures for mental health, such as ECT or electroconvulsive therapy, may require an extended stay in urban areas. They may be performed daily for a week or so. And so just for the kind of to speculate kind of a cost, roughly a few weeks ago, I looked up what it would cost to stay at a safe and clean motel in Fargo, North Dakota, because we know there's a big difference between a motel and a safe and clean motel. And for 5 days, and it would run somebody about $361 for one person in a single room. And that cost would not include meals or transportation. Farmers and ranchers may have to wonder who will watch their place when they're gone for more than a day or two. Especially ranchers, people who have livestock like horses or sheep. Those animals are so dependent on them for their food and for their water, especially during the winter time in regions where the climate changes a lot during the winter time. Ice, water freezes up and it's ice. So you need to make sure your animals have a place to get a drink. During the summertime, I know something that my brother and my dad have to do frequently in the summertime is actually haul water to the windmills because it'll go 4 or 5 days without the wind blowing, and then so your windmill's not doing anything. It should be able to pump water out of the ground, but there's got to be wind to do that. So these are I mean, when I say they have to haul water, you have to do that 4 or 5 times a day because one cow can drink a lot of water, and a couple hundred cows can drink a lot of water. So for acceptability, stigma plays a really significant role in rural mental health. People worry that their neighbors and family, friends will think differently of them if they found out they were seeing a mental health professional. They don't want to be seen as unstable or crazy. Mental illness is often referred to as a no casserole illness because people do not react with the same support and comfort like they might if the person had been diagnosed with cancer. And in cases of physical illness or death, rural communities often rally around those families by bringing them food and offering emotional support, making sure those people aren't alone, if they want company, to make sure somebody's there all the time. A lot of rural areas, I know in the United States, have like calling trees where like the county has a calling tree. So like if the Smiths just lost Bob Smith to a heart attack, and people get on the phone with calling tray, I'm going to bring food for them on Saturday and Wednesday. And I know that Carol Smith is going to want people to be with her. So why don't I go over there on Monday afternoon since you are working at the library that day? Like they make sure everything's like covered. The same cannot often be said when a family is experiencing a difficult time because a member of the family is recently hospitalized for something like bipolar disorder, or after a loss from something like suicide, or even involvement in homicide or something like that. In the wake of my uncle's death from suicide, the community became very tight-lipped about what had happened. For many years, most of my family referred to this event as when Ole got sick and passed away. People in rural areas quickly identify where one would go for those kind of services. So even having somebody see your vehicle in the parking lot might start rumors about the state of your mental health or what's going on with you. Are you and your wife having problems? Is there a kid, not right? People will use that term a lot too, not right. There might be a lot of uncertainty about what to expect from an appointment with a psychiatry provider or therapist. Because of, in the United States, and I know that this is actually something that applies in many other countries outside the United States, because of institutionalization, which continued until the late 80s. In America, at least, there's a lot of people that still have a lot of fear of being institutionalized or being put away, because that was very often the response, even to things like he would be my grandma's nephew. So her brother and sister-in-law's oldest son, Kenny, Carol had a hard time with her delivery with him, so he was deprived of oxygen during his birth. And this was, of course, keep in mind, this was in like the late 40s, so this was a long time ago. And he probably had like shoulder dystocia or something like that. But he's always he has an intellectual disability, and my dad's talked many times about how hard the doctor tried to get them to institutionalize Kenny. It's saying like he's never going to be right, he's always going to be slow like this, like this is a big burden for your family, your husband, you have this ranch, you have other, they, especially as they started having other children, this is going to be hard for your son and your daughter to relate to their older brother. And they were just very insistent, no, this is our son, he is our son, he's going to live with us in our home, like we are going to take care of him because we're his parents. But that was something that was very much like even things like intellectual disabilities, autism, which we didn't have a word for at that time, or something that a lot of people experienced that, and so they still are fearful that could happen to them too, or to their kids, to thinking like, oh, well, thinking like if a person has like an older member of the family that happened to, thinking like, oh man, I don't want people to know my kid has ADHD. Because what if they try to take them away from me? What if they try to get me to put them away? So what if those rural communities were able to become more comfortable with offering support to those experiencing mental health issues or towards families who have lost a loved one from suicide or substance use? What if those communities changed the narrative of no casserole illness? What rural communities already have the inherent strength of being very supportive during other hardships? It's not uncommon for rural communities to have groups of people who meet for coffee to chat. Imagine if those coffee clubs, so to speak, were to invite the local therapist to come and meet people so that they were no longer the head shrinker and they were just a member of their community. There are also some resources that come out of those concepts that have been very helpful to families and individuals. Here in the Midwest, specifically in North Dakota, this organization is active as an organization called Farm Rescue that offers support to agricultural families who are experiencing a serious illness or injury. I was already familiar with Farm Rescues when I worked in the emergency room. There was a person in that community who died very suddenly from a heart attack, and it was right during fall harvest, and so they had fields and fields and fields of wheat and corn that they were still harvesting. And at the time, all their kids were living outside of the community. One was in school for agronomy, and a couple of them lived in the city and weren't planning on pursuing agriculture at all as a career. And so when their father died, very suddenly they get a widowmaker heart attack. They were thinking, oh man, how are we got to pay the bank back? The operating loans do. Remember I was talking about those operating loans. And Farm Rescue actually like harvested all those crops for that family. They came together, and so Farm Rescue is a network of volunteers, and they came and they harvested all those crops. The family was able to pay the operating costs back to the bank, and they were able to have that peace of mind that they didn't have to worry about how they were gonna, get the place sold probably, but also make sure those crops got harvested from the field and that operating loan didn't get dispersed among the kids as a debt. But I wasn't sure like what what all they covered. So this is kind of an example of sometimes you just make those connections as a service provider. So I reached out to them, and I heard back from them within a day, and I'd asked them like, what about substance use? That's a big one. That's a sticking point for a lot of people, is that it's hard enough for them to accept things like bipolar, schizophrenia, depression. It's really hard for them to accept that alcoholism or drug addiction isn't like a character flaw rather than an illness. So after I had emailed them, they had responded back that they have helped families who are experiencing crises from both emotional and substance use issues. I was really pleased to hear that. So I was saying, providers serving these rural communities can tap into those existing resources and forge those closer connections so that those warm handoffs can happen, so that it's not just, well, I think Farm Rescue can help you, but I don't know, you'll have to call them. Because again, that stuff people are really coordinating on their own usually, and without the help of a social worker or somebody, so that it's hard to find social workers that want to live in rural communities too. And sometimes the work is really spread thin among like the nurses and stuff in those smaller healthcare facilities. So as much as we, the whole team can do to make sure that they're acquainted with what is out there for services and can do those warm handoffs of like, we need to get in touch with is so and so at Farm Rescue, because I do know that they do help whenever people have a mental health issue in their family. So I really think you should reach out to them, because I think they might be able to help you out with getting some of those, some of your hay put up or whatever. Take that burden off of them, that work and let them focus on what what's going on. So I think that increases our comfortability to as service providers of making those referrals too, and knowing that we're not kind of just putting a line out there that might not even result in anything. Agricultural entities are also taking more initiative to be proactive and offering resources. And those entities are folks in those industries already, and they're already interacting with them. So such as like the example I thought of here in North Dakota is the North Dakota Farmers Union. That's already going to be something farmers are super well acquainted with. They're already interacting with people in the Farmers Union, already familiar with probably, if they're a little tech savvy and been on their website, they're familiar with how to get in touch with them and all that. And although they're not mental health industry, agencies, they are aware of the power they have to connect with people in those services and make an impact on the mental health crisis that's affecting so many rural communities. Changing the terminology for services can be really effective for increasing willingness to utilize services. In the rural community of Holly, Minnesota, the REACH program saw a significant increase in people accessing counseling when they switched from referring to it as counseling to stress management. They had like a huge influx, especially of older males that were coming to counseling then after that. And because REACH is an organization that doesn't only offer mental health services, they also offer a whole bunch of other services. It's not that like, well, they're in the program of that REACH building, that means that they're totally off their rocker. It could mean that they're there for their credit building class. Maybe they're there for the update that the Farmers Union is giving on changes to the new farm bill. There's so many different things they could be there for. Doesn't mean that they're there for counseling. So integrating mental health services into primary care in the way that places like REACH have integrated mental health services into what the other things they offer too, creates opportunities to see those mental health providers without having to have that pointed out to their community. Utilizing those peer resources is important too. Behavioral health services don't have to be exclusive to therapy or psychiatry. Groups or peer support can be just as impactful. And I'd have to say, in America, we're a little behind on that. So if there are people doing it from countries, like Australia has been using peer support for, I think, like a few decades. So we're really pretty behind. The Northern Lights Clubhouse in Ely, Minnesota. A lot of people aren't familiar with. Ely is a super tiny rural community in Minnesota. That's a really great example of peer support. The clubhouse does not use therapy, counseling, or psychiatry. Its sole focus is on peer support and social interaction. So here I pulled some screenshots from some of these organizations. So the one in the top left there, that's some of the marketing kind of stuff that Farm Rescue uses to make sure that people are aware. They're at pretty much every county fair, any kind of event like that. There's a big farm show in Fargo here every year called the Big Iron Farm Show, and their Farm Rescue is always there at the big booth. There's very specific language that's the non-shaming too, right? It's focused on the strengths of these communities. So specifically this one here, #FarmTownStrong, together we'll overcome the opiate epidemic. And it says in here, it's talking about the resilience of our communities, teaming up, providing information, the opioid crisis has struck these families a lot harder than the rest of rural America. Um, and it's like very non-shaming language. The burden they carry can be overwhelming. Not you're depressed because you can't quit being sad or whatever. If you can't feel happy anymore, call this number. It's, you have a heavy burden to carry and you're doing a lot of hard work, and that's understandable that you might be having a hard time because of that. And then that bottom right one is just some of the events that are at the Northern Lights Clubhouse. I thought were kind of cool, just very casual language there, very, I feel like, like non-committal to like make it if you can, and would be happy to have you. Here's the things that we have going on. Making sure, I thought something that was really great with the meditation group is it's saying it's not a religious practice, because the vast majority of people in Eli, Minnesota, I can guarantee is this way, and everywhere in Minnesota are probably Lutheran. And I think there's a little bit of a thought that things like yoga and meditation, this is kind of what I've gotten this kind of experience wise from working with a lot of people, belong to the Lutheran or Catholic faith, is that you're becoming a Buddhist or something, or Hindu, or practicing another religion if you engage in yoga or meditation, because there's not super familiar with that those things can be applied in a way that's a little different. So I thought that was really great too. So that schedule looks like it's updated really regularly, and that's again ran by all volunteers. It's strictly peer support. So, although mental health services in rural areas are sparse, there's barriers to those services. The strength of those communities can serve as the foundation for building up those resources in rural communities. Considering adaptive approaches that utilize those strengths that are already there and encouraging emotional wellness are becoming something rural communities are more comfortable in discussing. And I think once you get people more comfortable, I think that's something that's really key. Is it really is a really severe situation, but my wheelhouse of things is going to be statistics in the United States. And I know probably one of the most alarming things I've heard in the last few years is that the only demographic for suicide rates that has went up instead of down or stayed steady is older men that live in rural areas. And it is especially a risk factor if you are a farmer or rancher. The suicide rate has been steadily climbing over the last 10 years for those folks. That's significantly higher than it is for the rest of the United States. And for other demographics of that, same age range in rural and urban areas. I mean, so that's really concerning. That means that there's there's a lot of people who are really in need of help, but they're not accessing those services at all, is kind of what the data suggests. It's not people who are, it's what we know, unfortunately, is people who are most likely to commit suicide are not connected to a therapist or a psychiatrist whatsoever. But they have probably seen their primary care provider in the last 30 days before they committed suicide or attempted suicide. So that's something too that is, and even though Fargo Moorhead is the community I work in is the most populated area in North Dakota, and it does have a population of, I think we're like just a little over 400,000 people now. Something that this community has done is implemented, in most primary care clinics and the ambulance service, the police have all implemented the Columbia Suicide Severity Rating Scale as an automatic thing that is triggered for, because that Columbia was created specifically so that it could be applied by anybody. You don't have to be a healthcare professional to do the screener. You can, I know at Essentia Health here in town, they're the people who answer the phones and make appointments do the Columbia with you, whatever you call. They say, have you been feeling down, blue, depressed, hopeless? They do the PHQ too. And then if somebody says that, yes, they've been thinking a lot about death or feeling depressed, they ask them the Columbia as well. So that's somebody who I think knowing rural people the way I do, like firsthand, I think could feel for a lot of rural people a lot less intimidating than talking to a doctor about that, because they're gonna see that person answering the phone or taking their, appointment or whatever down as somebody who's just like them, who isn't a doctor or a nurse, or somebody who maybe is a little intimidating to them. So they might be more likely to say, yeah, I've thought about that, or I do, I kind of think that way sometimes. I don't know what's going on or whatever. But that would be, it serves as like that very critical point of contact to try to get something going for that person before. um, Another scary statistic about these rural communities is that there's the most common form of suicide attempt or successful, whenever somebody is complete suicide, is that the most common form of that is using a firearm, and we know that that's probably one of the most lethal forms of suicide is from a firearm. So it's, men are more likely to use a means that they know is going to be successful, as they don't want the shame and not completing suicide or having to live, as that person who tried to kill themselves or what have you. So that's really critical, that because there's probably going to be just one attempt, right? It's going to be the one that ends their life most likely. So I think really, that things like some of these resources I saw really did a good job of framing, mental health issues as something that can be terminal, that are, that can result in loss of life. And I think that's something that, people, that catches people's attention more too. So this is the point I have for Q&A. I'm actually like 5 minutes early, which hardly ever happens. So
Well, thank you. That was incredible. And I can't speak for everybody, but I'm hopeful that I can, that, some of the statistics are alarming, right? And you hear all the information that's coming through about how rural communities are experiencing high rates of suicide, and especially as it comes through to farming and ranching agriculture. But to put it in the statistics it's terrifying. It's interesting how, when you were talking about terminology, I'll just share this really quick while people are, I should say, if you have any questions, please feel free to go ahead and share those now. We were fortunate at GRNEN to be connected with a group in New Zealand. They're called Surfing for Farmers. And it sounds a lot like what you're speaking about, where they identified, because there's a lot of ranchers and farmers in the rural communities in New Zealand, and they identified the stigma of seeking help for mental illness was preventing people from getting the help that they needed, and that was resulting in, as you coin it, that terminal cases. So they put together this Surfing for Farmers program, and it's really just kind of like, hey, you don't have to know how to surf, you don't have to have the equipment, you don't have to anything, just come on out, we're going to surf, we're going to have a barbecue, we're going to hang out. And it was a way to bring people of that community together, just to lighten the load, to have fun, to step away from the farm. And they were finding people were traveling for up to 2 to 3 hours to participate in those programs. And they expanded it countrywide, which I thought was really interesting. So a lot of, it's nice to see a lot of things that are happening to like change that terminology, as you were saying. So if there are any questions, we can go ahead and take those. Also want to take a quick minute to share, if anyone is interested, next month, as part of the series, we're actually hosting a training webinar that will result in a certificate, and it's called the QPR training seminar, which is question, persuade, and refer. And Dr. Kiefner, who is the University of South Dakota, is going to be hosting it, and she refers to it as CPR for suicide. And the whole training session is really to help train professionals how to recognize signs of warning signs, of suicide, how to offer hope, and understand when and how to save a life, when to seek help, how to keep that person as stable as you can until you can seek help and save a life. So that should be, I think, a perfect follow-up to all of the great information that Whitney has just shared with us today. If you are interested, that is on our website. There is a 35 capacity limit just because it is a certification program, complimentary, of course, via GRNEN. But if there are no questions, what we'll do is we can go ahead and let you get back to your day, because we do appreciate everyone making time in their schedule to join us, as always, for this incredible information. I know Whitney shared her contact information earlier in the seminar. So if you have any questions that you think of down the road, I know a lot of times when we process information, sometimes you come back to it and say, oh, I wish I could ask that. That's why she shared it, and you can always connect through the GRNEN website as well through our collaboration pages. So thank you, Whitney. We so appreciate your willingness to be here today to share all this incredible information, and for your time. Everybody, I hope you have a great rest of the day, the morning, the evening, wherever you are calling in from, and we will hopefully chat with you again very soon. Take care now.
Thank you.